In fact, when I thought of preparing this, I was during my training, when I see a patient of retinal vasculitis, I was scared. And in fact, the diagnosis is tricky. And the problem is the retinal vasculitis is associated with several sight-threatening diseases, but not only sight-threatening diseases, but life-threatening diseases. So retinal vasculitis is a sight-threatening inflammatory eye disease that involves retinal vessels. By definition, it is exudates around the blood vessels or white sheathing or cuffing. There is an important piece of information that we should know before proceeding with this lecture. We have to differentiate between inflammatory sheathing and non-inflammatory sheathing. We know non-inflammatory sheathing, which accompanies hypertension. For example, it is well defined, long segments of sheathing, but in inflammation, we usually have focal frothy cuffing. So, the retinal vasculitis may be asymptomatic. This is the majority of the cases. The patient may complain of floaters or decreased vision or a lost part of the field of vision. Is it important to diagnose retinal vasculitis? As I mentioned, yes, of course, you have to know what is the underlying disease. And as in cases of uveitis, we have more than 150, 160 causes of retinal vasculitis. But I always like to tell my patient, we have this number, but we divide them into two major groups, either infectious or non-infectious, of course, with the addition of masquerades and others. But here in retinal vasculitis, we can have infective etiology, neoplastic, systemic inflammatory disease, neurologic or isolated idiopathic condition. Of course, we have very long list of organisms. I always keep telling my patient any organism on earth can cause uveitis or retinal vasculitis. I know this is not scientifically true, but we have this long list of organisms that can cause retinal vasculitis. These are only bacteria. And we have the viral causes. We have the whole group of the herpes family can cause retinal vasculitis. The parasitic etiology is mainly the toxoplasma, and we have also rickettsial disorders. We have two important neurological disorders that are associated with retinal vasculitis. These are the multiple sclerosis and Susac syndrome. Malignancy, we have paraneoplastic syndromes, and I have seen cases of CAR, cancer-associated retinopathy. With breast carcinoma, we have retinal vasculitis. Of course, we have to put ocular lymphoma and acute leukemia in our differential. Now, coming to the most exhaustive list, we have systemic inflammatory diseases. We have this long list. I will not read it out because they are actually a lot. So you can see what is the problem, what is the difficulty in getting the diagnosis. And to make things further complicated, we have specific ocular conditions like frosted branchiolongitis, idiopathic retinal vasculitis, aneurysms, and neurotinitis, acute multifocal hemorrhagic retinal vasculitis, barciplanitis, and Birdshot. So what is the differential diagnosis? So the aim of my talk now today is to give just some few clues to narrow the differential diagnosis based on the clinical presentation alone. And to be honest and to acknowledge this, most of this presentation is adopted from a famous paper by Professor Ahmed Abul Asrar, Dr. Karl Herpert, and Dr. Monsef Khairallah. In fact, they wrote a very nice paper in the literature about retinal vasculitis, and I liked it, and I liked their algorithm. So if you answer these questions, you can narrow your differential diagnosis. The first question you ask yourself when you see a retinal vasculitis, does it affect an artery or a vein? Second, is it focal or diffuse? Any associated retinal lesions? Is it ischemic or not? Let's see how can these questions help us. The first question, does it affect artery or vein? It is the K question to answer. As we can see here in this patient, the vasculitis affects mainly the veins. This is a periphlebitis. So you have a periphlebitis, you should think of these disorders, and these are the most common diseases, and the periphlebitis is more common than periarteritis. So you should think of Behçet's disease, TB, sarcoidosis, MS, barciplanitis, and Gale's disease. But in the case of the arteries, periarteritis, I will give you a clue. Think first of the systemic diseases down. And this seems logic. If you have a systemic vasculitis, and the patient is known to have systemic vasculitis, it will affect the arteries. And then you have the infections. We have viral retinitis, toxoplasmosis, and syphilis in addition to the ERVAN. So again, when you see a patient with vasculitis, you should categorize them. Is it affecting mainly the veins? And then you know the differential. Is it affecting mainly the arteries? So you have a more common causes. The second question is it focal or diffuse? Focal sheathing is associated with MS, sarcoidosis, and TB. So if you did the fluorescein angiography and you find focal sheathing, you should think of these three entities. This is the case in fluorescein angiography, and in the fundus picture, you can see here the sheathing is focal, just focal, it is not diffused sheathing, and the fluorescein angiogram also it is clear. So if you have this focal sheathing, you have to think of these three entities. The third question is the associated retinal lesions. We have in fact several types of retinal lesions that we can see in patients with retinal vasculitis. Cotton wool spots, if you find cotton wool spots, this is associated mainly with systemic vasculitis like SLA, polyarteritis nodosa. So now we have two things with systemic diseases. They affect the arteries and they are associated with cotton wool spots. It is expected because they will cause periarteritis, ischemia, and cotton wool spots. The second type of retinal lesion is retinal infiltrates, and as was nicely illustrated earlier, if you have retinal infiltrates, intraretinal infiltrates, it is infectious still otherwise proved. If you exclude infection, it is pathognomonic of Behçet's disease. So you can see, if you have retinal vasculitis, retinal infiltrates, you can narrow your differential. Necrotizing retinitis, it is another form of retinal affection, and as we all know, it is associated mostly with infection like ocular toxoplasmosis, acute retinal necrosis, and cytomegalovirus. And sorry, these are the four lesions that we can have cotton wool spots, necrotizing retinitis, interretinal infiltrates, and the last one is the neuroretinitis, which is characteristic of Bartonella Hensley. So don't forget to look to the retinal lesions. There is also another important sign, which is aneurysmal dilatation of the retinal blood vessels. They occur usually with ERVAN, which is idiopathic retinal vasculitis, sarcoidosis, and long-standing cases, and they can be nicely illustrated by fluorescein angiogram. As you can see here in the last one here, you can see the aneurysm. Retinal ischemia. There are some causes that are associated with retinal ischemia, like TB, Eales disease, Behçet's, MS, and sarcoidosis. This is retinal ischemia with hemorrhage. This is also extensive retinal ischemia. So again, please, when you see a patient with retinal vasculitis, try to answer these four important questions. I will show some of the cases. If you'd like it to be interactive, it will be nice. It's a 31-year-old male patient with mild anterior uveitis, and by fluorescein angiography, it showed this. Can you see this? We'll try to answer the questions. Does it affect arteries or veins? I think it affects veins. It is clear here it affects veins, okay. Is it focal or diffuse? Focal, okay. Retinal lesions, we can judge here. Is it ischemic or not? Ischemic, good. And this is the other eye, it shows almost the same. So we have panuveitis in both eyes, we have occlusive retinal vasculitis. So if you do the meshing, occlusive retinal vasculitis, these are the causes, and the focal sheathing will make it more narrow, so we are suspecting now MS, sarcoidosis, and TB. That's why we ordered the labs. BBD was positive, MRI of the brain to exclude MS, that we suspected was negative, and the ACE was normal, so the patient was diagnosed with ocular tuberculosis. And this is based on, mainly we tailored our lab based on the clinical presentation. Another case is a 48-year-old female patient, blurring of vision in the right eye, 1-week duration, vision is hand motion, afferent pupillary defect. In the right eye, 2+ cells and 1+ flare. This is the fundus appearance. Can we also answer this question? Does it affect the vasculitis? Is it clear here? Is it clear? I think we have an area of vasculitis up here. Does it affect artery or vein? It's venous, mostly it's venous, it affects the vein. We have snow pools also. Is it focal or diffuse? It's focal, it's the part in the upper part here. So the focal sheathing from here, from this picture, we narrowed the differential to MS, sarcoid, and tuberculosis. MRI of the brain was done, and it revealed classic features of active MS. And this is based on narrowing the differential diagnosis, and chest X-ray was normal. So our impression was intermediate uveitis, peripheral retinal vasculitis, and multiple sclerosis. The third case, 48-year-old male patient, complained of blurring of vision in both eyes of 5 days prior to presentation. He has a maculopapular rash on the shoulders, aphthous ulcers, no genital ulcers, and we have this clinical features. We used to see this in advanced stages of a certain disease, but if you can judge here, it affects arteries or veins. It's veins mostly. Is it focal or diffuse? It's diffuse. Any associated retinal lesions? Yes, we have retinal infiltrates here. Ischemic or not, we can judge from the fluorescence, from just here. And again, just to emphasize, if you have interretinal infiltrates, this is pathognomonic of Behçet's disease if you exclude infection. So we have several other cases, but because of the sake of time, so it is just a very simple guide. If you have a patient with retinal vasculitis, don't panic. Try to ask yourself these questions. Use all the data or the knowledge you have, then tailor your differential diagnosis, and of course, you can ask the help of our rheumatology colleagues. Thank you so much.